Welcome to the next episode of Endoscopy Essentials. We have a very serious topic. We have a very serious guest, Michal Kaminski from Warsaw. Welcome.
Yeah, thank you for having me, Thomas.
We had this podcast about your JAMA paper about the ADR cutoff, right?
Yeah.
And so we were diving with Nastasia a little bit into colonoscopy quality, and that's a topic we want to start today. I'm sure we won't finish it, but let's touch a few aspects.
Sure.
And you have spent your life with this topic, right?
Yeah, honestly speaking, right now I'm a little bit overwhelmed even with colonoscopy quality. I mean, sometimes I'm being blamed for, rising ADR thresholds too high, and people are looking at me, oh, this is the guy who pushed us so much to rise our ADR levels.
The bad ADR guy.
Yeah.
But for the rest of the world, I think 26% is quite reassuring. It's not too high, at least in the primary colonoscopy.
Yeah, I think that it's pretty reasonable, I would say.
So before we start, there are a lot of other factors, right? It's patient selection, at least for diagnostic colonoscopy. It's colon prep, it's informed consent, everything. What are your top 5 issues before it comes to colonoscopy?
So honestly speaking, Thomas, as you mentioned, I've been in this field for quite some years. I remember my first talks with doctors in Poland when we tried to establish ADR as a quality benchmark. And they were all saying, Michael, I have this special patient selection. I don't believe in that because the differences between different endoscopies are too large to explain the differences in ADRs that they have or differences in detection rates.
Even from the same area.
Yes. So obviously, you have a case mix with very young people, predominantly women and so on. You may have slightly lower ADR, though the differences are not that high. So what really matters is how meticulous you are in performing your colonoscopy. And I think that this is the critical factor.
What about colon prep? There's a lot of noise about that. Is there a threshold when you should stop, or what's your advice here? Or should you invest more time in cleaning?
Obviously, we right now have guidelines, and those guidelines say, you have to have adequate bowel prep, which is like if you use a Boston Bowel Preparation Scale, you should have at least 2 points in each of the bowel segment. If you don't score at least 2 in each bowel segment, then you should repeat your colonoscopy within 1 year. And there is some Spanish data to support this early on colonoscopy. So this means that you should reach at least 2 points. And obviously, usually those who say, oh, the bowel prep is not good enough, they tend to blame patient. And I don't like to blame patient because first of all, we have to explain it really well, how you should use a bowel cleansing. And second of all, once the patient is in your endoscopy room, you should clean and suck. This is the mainstay because you assess the Boston Bowel Preparation Scale only after all the cleansing and suction maneuvers. So it includes not only, let's say, patient compliance with bowel cleansing, but also your explanation or how you organize it in your practice, and also how meticulous you are in cleansing and suctioning all the remaining debris from the colon.
Let's stop for a second here because that's very, very important. It's not always clear from the papers, right? What's the cleaning scale? Is it before cleaning or afterwards? So you have a clear preference for the final end product, which is dependent on both the patient and the examiner.
Yeah, if you use, I think that Boston Bowel Preparation Scale is the one which is most widely used nowadays. And this scale was validated as such that you assess it only after all the maneuvers, which means that you have to, spend some time in cleaning. But obviously, if you ask me whether cleaning is important or cleansing is important, It is, obviously, because I've started my career when cleansing was really poor, and it changed over those 20 years really significantly. So this is the first thing. But then we have also some data. Beforehand, we didn't have any data, but right now we have data from so-called root cause analysis. So when they analyze the reasons for post-colonoscopy colorectal cancers, let's say in good, well-organized practices, half of the post-colonoscopy colorectal cancers were due to missed lesions, but they were assigned to inadequate baseline examination. This means that they either did not reach cecum or had poor bowel preparation, inadequate bowel preparation. It shows that it's a significant contributor to post-colonoscopy colorectal cancer, because you have to take care of cleansing and because you have to take care of rescheduling the patient within a year if the patient comes and is not clean enough.
Any tricks? If you go to the cecum, the ascending colon is mostly the most dirtiest part, and if there's coverage, not firm stools, but what do you do?
Oh, that's really tough, honestly speaking. I mean, when you encounter all that, I mean, there are obviously some, let's say, Japanese reports, mostly on Asian reports on, I mean, how to assess and be sure that the bowel cleansing is good. So you have this really funny pictures that they ask to each patient coming into endoscopy practice. Okay, does your stool look like that? If it doesn't, then keep on cleansing more. If it does, then you can come over, because obviously once you reach the cecum or once you reach the right colon, I mean, it would be like difficult to somehow reschedule and ask patient to drink some more. But obviously you can do it if you organize your practice. You can ask a patient that comes to you before colonoscopy, and if you have like longer time to assign the patient, then you can ask, okay, so please add some bowel cleansing on top of what you did, because bowel cleansing works pretty fast.
So informed consent is very important, that the patient knows what he's doing.
Yeah.
Okay.
I think that there is really good evidence behind that we should be using not only oral communication with the patient, but we should also use a paper instructions for bowel prep, and also use some of a advanced cleansing enhancement techniques. There is several things that you can use. I don't think that we have all the time to discuss all that, but there are several different things like apps or some kind of reminders and so on, educational videos. They all work, and there are randomized trials to support this topic.
So it should be taken seriously. That's the message by the team and the patient, right?
Yeah, for sure.
Yeah. Okay. So do you prefer a normal colonoscope or pediatric ones? Because the normal ones have a bigger channel. Does that help? Yes. Huh?
Yeah. I do routinely use a normal short adult colonoscope. I don't use pediatric. I like to have a large section channel. Also, the quality of imaging is seems to be better with the normal adult colonoscope. So I think that I prefer the one.
Next issue is sedation. There is some evidence in the upper GI tract that if sedation is adequate, you are performing better. The same true for the colon, because the habits are widely varying between countries, from anesthesiology and propofol like hell to nothing.
Yeah. So Thomas, I think that there are numerous believers that, I mean, you can do colonoscopy only, let's say, under sedation or with anesthesia, and otherwise, I mean, you won't detect lesions and so on and so on. So there were several tries to prove it, but we don't have any proof that sedated colonoscopy or with anesthetist really helps. The point is that you have to have really meticulous and very good quality of colonoscopy withdrawal insertion as well, in order to make it happen without sedation or with moderate sedation. So it means that your training has to be really focused on how to insert your colonoscope without causing a pain to the patient. And honestly speaking, I think that you can make it happen to more than 90% of people who are coming and showing up for your colonoscopy.
Okay, I would get a very different answer from other countries, but
I know.
I think we leave it with that. There's also that discussion looking on introduction or making introduction fast because it's less painful. What's your reply?
Yeah, I mean, there are some reports that, I mean, there are some polyps which are, encounter on your way in, so you may wish to take them out or spot them. I think that, honestly speaking, we prefer, and there is also some data to support that, to introduce the scope as fast as possible and also probably at least partially underwater, because you will cause not only less pain to the patient, even if the patient is sedated, but also you will have a better access to every single lesion. You will not have looping, so your withdrawal will actually be also easier, because if you cause looping, it is not only that it causes pain to the patient, but also it causes that your scope just falls on your way out. So it means that you cannot obtain a really stable position of the scope. So it all relates to the quality of insertion, and I think that there are several maneuvers that you can train yourself, and you can manage to get to the cecum with a short scope.
But on the way in, if you see a small polyp, you probably take it out because you may not refind it.
Yeah. I mean, if it's really like a small polyp which is hidden and so on, yeah, I may wish to take it out. But if it's a, let's say, 5 to 10 millimeter polyp already, I think that I will just keep it for my withdrawal, because I keep, honestly speaking, even before the introduction of water immersion, I mean, we were always doing water immersion in the left colon without calling it like that, because this was the technique that we were using just for years. And then we've realized, oh, this is right now called water immersion or water exchange technique. In the left colon, we were always using that.
So all things coming back.
Yeah.
Okay. So you're in the cecum. One issue which some people do consequently, others are afraid, is inversion.
Yeah.
Right-sided inversion.
Yeah, that's.
Is it dangerous?
That's very nice. That's very nice question. I think that people are saying that it may be dangerous, but I think that with new, really flexible endoscope, some of them with some special technologies which allow for better bending, I think that it's not really dangerous. And if you follow certain rule, it's really easy. I mean, it's not time to explain it all, but there is also a very nice instructional paper from Doug Rex, I believe, who explains exactly how to, rotate yourself, how to behave in order to perform safe retroflexion in the right colon.
So I think we place it in the show notes that everybody can look it up.
Yeah. That's brilliant. And actually, I think that right now, you asked me, I think that we have a really nice slide to share with you, which shows that retroflexion in some difficult scenario can be really of help. So what you can see on the slide on the left-hand side, you can see a scope in white light in retroflex position. We are somewhere in ascending colon. And you can see on the proximal aspect of this haustral fold, which typically in the proximal colon is really high, you can see a lesion. And if you get closer to the lesion and look it up in narrow band imaging, and you have it on the right-hand side, you will spot that there is a depression, there is a demarcation line, and that this small lesion is actually a deeply submucosal invasive cancer, which you can predict from JNET classification. So it's a tiny, deeply submucosal invasive cancer, which I think could easily be missed in forward view. On the other hand, if I can mention one thing more, because obviously there were some randomized trials showing that if you retroflect in the proximal colon, you will increase your ADR in the proximal colon. But then there are some others that showed that just the second pass in forward view will also help you to visualize and increase your ADR and visualize better your colon. And honestly speaking, I think that we should spend the messages. We should spend quite some time in right colon because the folds are really high. So you really have to make sure that you assess also the proximal aspect of haustral folds, which is, I think, quite critical to the issue of ADR in the proximal colon.
So your recommendation is a systematic retroflexion in the right colon?
I wouldn't say systematic. I would say either retroflexion if you have really high folds, or at least two passes in the right colon, so that you make sure that you have seen everything in the proximal colon. And honestly speaking, I spent much more time looking at proximal colon than at the left colon. And I think that I spoke to several people who are doing more or less the same, because lesions are more difficult, the situation is more difficult.
Okay, if we take this example, we can take a quick side road.
Okay.
And the question is, if you see something like that, leave the snare in the cupboard.
You mean
don't do normal EMR?
Yeah. This is quite obvious. So I think that if you see this kind of particular lesion, you have to assess it really carefully at first, and we partially did it. I mean, you can see how we look at the lesion, and then you should discuss with the patient. You should take into account patient comorbidities, patient preference for the treatment. You should discuss with the patient, because this is not going to go for standard EMR technique. This for sure entails either advanced resection technique or even surgery if the patient is really young and so on. But I think that with current techniques, we can think about advanced resection techniques for this kind of cancer.
Okay, just for a second, I think, if you see this in a setting where you can't do this, okay, send it to a reference center, but you are a reference center. So when you see this during a normal day colonoscopy, would you do it on the same day or reschedule the patient?
I would certainly reschedule.
Okay.
I think that there are several things that we've learned. Obviously, you cannot perform advanced resections under time pressure. And usually if you do screening colonoscopy or diagnostic routine colonoscopy in an ambulatory setting, outpatient setting, I mean, it's difficult. Then, especially with this kind of a lesion, you'll have some complications which you may have not discussed with the patient upfront. And it's difficult to discuss with every single patient what happens just in case that you find a tiny deeply submucosal invasive cancer. What should we do? So because it rarely happens. So I think that it's wise to reschedule, to have a proper time schedule for this kind of a procedure, and to prepare yourself with a scope, nurse, all the devices that you may need, and so on and so on.
Not going into too much detail, but what would you do, ESD or full thickness? It's not so big.
Yeah, honestly speaking, I think that for myself, and you'll hear different approaches worldwide, I can imagine, I would certainly go for EFTR. First of all, because this shows a JNET-free pattern, which tells us that probably this may be a deeply submucosal invasive cancer. And honestly speaking, I know the histology, so it's much easier for me to tell you as well, because obviously we can talk as well about JNET and how accurate it is. Nevertheless, for sure, you should suspect deeply submucosal invasive cancer. And we are in the right colon. We are in a retroflexed position on a proximal aspect of a haustral fold. ESD would be a nightmare, a very difficult procedure, And taking into account that this is a probably deeply submucosal invasive cancer with a very low chance for R0 or curative resection. So if you want to give it a try with endoscopic resection for JNET-free lesion, you should probably aim at full thickness resection. Okay. And this is exactly a lesion which I think is a lovely one for EFTR.
Good. So let's leave this side road because we want to get back to quality. So retroflexion or double scoping of the right colon is the message. There are a lot of aids, mechanical aids, AI. What do you use? Do you have an example maybe?
Yeah,
AI picks up visible polyps, small polyps, elevated ones, but they still have to improve all systems, right?
Yeah. So first we can talk about some add-ons that you may add on a device, and there is quite considerable evidence behind, for example, Endocuff that can be of help. There are several randomized trials showing us that you may indeed increase your ADR with this kind of a device.
Especially if you are below 26, remember.
So thankfully, I'm not below 26, so I'm not using personally it routinely, because I know that you are a lover of Endocuff. No, but the point is that I think that it's really important to have a very good quality of withdrawal technique. And I think that really there is a landmark paper which was published many years back by Doug Rex, I think that in 2001, about how you can score your withdrawal technique. And it splits into, washing and sectioning. We were already talking about that the speed of withdrawal already at the time, back 2001, it was almost 25 years ago. Then it's about bowel distension, and the fourth thing is how well you assess the proximal aspect of Hausdorff folds, which I think really deconstructs what we need to do during the withdrawal. So the point for me is that if your technique allows you to inspect really nicely in so-called, I call it corkscrew view. Mm-hmm. So you just turn around in a corkscrew manner entirely, also the proximal aspects of the folds, then you are probably fine even without devices. But I think that it's also a very good training or teaching tool for those who may not have a perfect withdrawal technique. And there is also some evidence for that coming from UK, that even after withdrawal of Endocuff, there is some persistent increase in ADR, because probably people learned how to look better on the proximal aspect of folds, and that you have to look up there. Because for many years, I was not trained during my colonoscopy training how to withdraw the scope. Usually people were trained how to insert the scope, not how to withdraw the scope. Nowadays, I think that things changed quite a lot. But in the past time, nobody really trained us how to withdraw the scope, which is really
introduction
important.
Was the adventure.
Yeah.
That's right. Now, honestly, I mean, to finish up that discussion, I like the Endocuff more in the left colon because it stabilizes the scope better and opens up the folds. In the right colon, you often don't see it. You really have to specifically use it to flatten the folds. Then it's also good. But okay, so mechanical devices, yes, to some extent. AI is the big topic. What AI in quality? Is it necessary, or is it a training effect and then you don't need it anymore?
So I think that there is a big hype about AI, obviously, right now, and I think that it's going, obviously, to have a future. But the feature that we are having right now, readily available, because there are also, obviously, in the research some other things, so that you have just this, green blinking frame showing you where to look for. I don't think that I mean, it appeals to me so much because honestly speaking, the bottom line or understanding of quality for me is that you have to make sure that you expose the mucosa really well. And then to spot something which is on the screen is probably, at least in the colon, much less important. But if the AI tool will allow us also to monitor quality, to navigate the blinding spots, to do more, then it would be really attractive to me. And obviously there are relatively few examples when you may think, okay, but maybe AI can help me with a difficult lesion, because there are some difficult lesions in the colon. Usually they are not. But I have an example right now, and I want to show it to you.
Because they are mostly trained on elevated lesions, right?
Yeah.
So that's an issue to be improved. But I'm curious to see what you're going to show.
Yeah. So right now, I will start the video. You can spot from a distance that there is a ileocecal valve, which was caught also by AI, which is, no problem. And then you have this polyp on a fold, which, obviously we can easily see without any problem. And then we pull back, you still see the ileocecal valve, and then if you are really meticulous and careful, you'll spot this tiny, or let's say 8 millimeter depressed lesion.
There's a color change. That's the first thing you see.
Yeah, and then you see it. If you are experienced, you see it in between the folds, but AI can't spot it because it was not trained to spot this kind of a lesion. And right now, we look at this lesion even from a very short distance. We take a device to expose it, and it's not spotted at all by AI. It means that if AI would be trained with those kinds of lesions, maybe this could be of help for us. But for a moment, I don't think that they are trained well enough in terms of very difficult lesions.
More or less all systems probably, although we do not really know what's going on behind the scene. But I think that's a clear message that, for the smaller elevated lesion, it's a good tool. Especially what you can also observe if you have one polyp in spot and there's another one.
Yeah.
Then AI picks it up automatically, and you may be focused on the one and the other one, unless the nurse is also attentive and says, "Hey, doctor, there's a second one." But
So Thomas, there is a funny story or whatsoever. Polish people, they are very keen to pick up mushrooms. They really like to go into woods and pick up mushrooms. And if you are a mushroom pick-upper, let's say, if you like to collect them, you will get to know that once you spot one mushroom, you have to look around because they are likely to be more around you. So this should be this kind of a thinking that endoscopists or colonoscopists should have. Once you spot it, it means that it is really likely that there will be another lesion somewhere around, especially, honestly speaking, if it's a non-granular type lesion, which is difficult to spot. For some reason, you quite often see them a lot if you look hard.
Another short side road, maybe, if we speak about mushrooms. I hope that the Polish people are good in differential diagnosis.
Not always.
Yeah, because it can be dangerous.
Yeah.
More
so
dangerous.
Our transplant surgeons are happy from time to time. Yeah.
What's your opinion in brief? Differential diagnosis by AI, does it have any consequences, or do we have to wait for legal changes and stuff?
I think that for the moment, the tools, at least what data shows, are not good enough yet, and we need probably for some legal changes. But honestly speaking, I think that it's going to make some difference, and it will be integrated into our practice on a daily basis. So, it would be very difficult, to live or do colonoscopy without this kind of tool in the future, they will be upgraded and they will tell us a little bit better. So I think that it will have its place.
So the message, if I interpret you correctly, for AI is it will stay there. There will be up and downs, you know. You have to get used to it. It has to be improved, but it's there to stay.
Yeah, that's correct. And for, small adenomas or increase in ADR, we have very good evidence. I mean, there are meta-analysis of randomized trials showing that increases your ADR. So for sure, it works. Obviously, it also probably depends a little bit on motivation, which I think is really crucial, because what we've seen also, not from randomized trials, but from pragmatic implementation of AI, is that it didn't work so well after pragmatic implementation.
It made people lazy.
Yeah, yeah. So I think that it's probably a lot about motivation. This is actually, I mean, if I may reflect a little bit more about the past, I mean, this is what we spotted when we first tried to or identified poor detectors in Poland in terms of ADR. So we tried to understand what is happening, and we invited them to our center to do some colonoscopies together. And actually what we've spotted that most of them, they were quite good when they were really willing to do good colonoscopy. So they really knew when they made an effort, they knew how to make good colonoscopy, but they were not making it on a daily basis.
So AI is your best friend when you are a good colonoscopist and still continue looking around, and maybe AI will be disappointed when you expect too much. And don't look around, so it doesn't help you.
Yeah.
Okay, so we are almost at the end. I think we have really critically, but also in a very balanced way, discussed our aids. We need them. We might have different opinions. At the end of the day, a big issue is follow-up. You know, there are studies coming in the next year where you are also involved about different follow-up intervals. Who is the patient whom you should focus most?
So I think that there is increasing evidence that we are doing too much surveillance in general, and for sure we are doing too much surveillance for so-called low-risk adenomas, and we've already changed it in our European guidelines. Americans did not change it yet, so they are still scoping a little bit more for low-risk adenomas. And what is happening in clinical practice that we do scope more than it is written in the guidelines. So we want to be sure that the patient is safe and so on and so on. Then the other issue is on high-risk adenomas. And obviously the common understanding of high-risk adenoma is that it's an adenoma 10 millimeters or larger, or with high-grade dysplasia, or with villous component. And this is what we, for quite some years, were considering as a high-risk lesion. And then the patient was suggested to have shorter intervals. The point is, and right now it's 3 years, I mean, let's say in most situations, but right now we have also some evidence to suggest that probably villous component and also size of 10 millimeters is not, good enough, because probably we should focus more on lesions which are 2 centimeters or larger. We should focus on lesions with proven high-grade dysplasia, maybe also some numerous lesions. I mean, these are the patients that I would focus the most, because these are the patients at risk. But if you look at the 10-year risk of colorectal cancer, not advanced adenoma, but colorectal cancer, it's very, very low among low-risk adenoma patients, and it's very similar to what you observe after normal colonoscopy.
Exactly, but I agree. There is a hole in this advanced adenoma issue, because also databases show that these patients have still a worse prognosis, and there should be the patients who benefit most. So there's probably even a subgroup of advanced adenomas which we should focus much more.
Yeah, I mean, we've published a couple of years ago a paper on that in Gastroenterology suggesting that you can cut more in half of the group of high-risk adenoma patients if you apply the rules of 2 centimeters or high-grade dysplastic lesions, and it won't do any harm to the patient in terms of future risk of colorectal cancer.
Okay. So, Michal, I thank you very much. I think we could go on for ages with that topic. I'm sure we'll come back. But that was a very, very nice first introduction into quality and how specific you get if you touch certain points and how much evidence is needed at the end. So thank you very much, and I'm looking forward to further podcasts.
Yeah, thank you so much. It was a pleasure.